Hi everyone, welcome back to OncoDaily. My name is Emma Ter-Azaryan, and today it's a great pleasure for me to introduce our guest, Dr. Cathy Yang. I don't think Dr. Yang needs much introduction, but still I would like to briefly introduce our guest. Hi Dr. Cathy, it's very nice to meet you. Dr. Cathy Yang is the Associate Director of Strategic Relations and Research Partnerships at the Vanderbilt-Ingram Cancer Center, where she also serves as co-director of GI Oncology and co-leader of the Gastrointestinal Cancer Research Program. She holds the David H. Johnson Endowed Chair in Surgical and Medical Oncology at Vanderbilt University Medical Center. Hi, Dr. Yang. I would like to know about your personal story first, like what initially drew you to medicine and more specifically to gastrointestinal oncology.
I would say that thank you so much for having me here today. I am actually the first in my family to go into medicine. I come from an immigrant family, and I'm first generation born here in the United States. I was drawn into medicine for reasons unknown. I really enjoyed my rotations. When I was younger, I had a strong interest in medicine, and I really couldn't decide originally between law school and medical school. But then I ended up going back into medicine, and I really enjoy it. I feel like it's a great opportunity to continue my education on an everyday basis, but also my ability to help others, not only within the hospital that I'm currently working at, but also have an impact nationally, internationally, at a wider perspective.
So I would like to ask you, as we know, at Vanderbilt, you hold several leadership roles, including co-director of GI Oncology and director of the Young Adult Cancer Programs. What have been your top priorities in these positions?
I would say that the way that I think to prioritize, how did I get to these positions is really about, as a clinical researcher, which is what I am. I focus on clinical research largely in colorectal carcinoma, anal and appendiceal carcinoma, so lower GI. I think, in order to really become an expert in your field, it's really important to remain focused. And that's really where I decided to address kind of where I wanted to go with the field, kind of looking at all unmet needs in that patient population, whether it's colorectal cancer or anal carcinoma, for instance. And the way I learn what are the unmet needs is really by paying attention to my patients in clinic. To be honest, that's how I make decisions regarding clinical trial development, about how to pursue various subject matters for manuscripts. And then the most important thing, I think, for me, is really connecting with others. And so not only connecting with the patients, but also the patient advocates, as well as basically pharmaceutical companies, as well as those across the NCI and across ASCO, really trying to develop concepts for various patient populations. And that has really led me to my role as the GI section head for Vanderbilt-Ingram Cancer Center. In regards to the Young Adult Cancers Program, this is basically what I was seeing in my own patient population in my clinic. I've been noticing basically very young individuals in my clinic going back to 20 years now, where you note that these patients are presenting with more advanced disease. They're too young to be screened. And, I really wanted to try to make a bigger difference, because currently there's no data to suggest that these patients should be treated any differently than any other stage 4 colorectal cancer patient. So what could I do to support them during their treatment? And that's why I created the Young Adult Cancers Program. It's not just focused on colorectal cancer. It's focused on all patients, early-onset cancer between the ages of 20 and 45 to 50. And we really wanted to try to provide the best support possible for these patients because that is something that we're not necessarily getting from their outside physicians that may not be as familiar with treating young adults. So whether it's family planning, fertility, social work, financial toxicity, body image, perception, we wanted to make sure we offered various services that we could help support optimizing their overall care.
Can you share which ongoing or upcoming trials you're most excited about right now?
I think In regards to colorectal carcinoma and metastatic disease specifically, I don't want to say that I'm going to choose one clinical trial over another. I think what is really exciting nowadays is where the field is going in regards to molecular markers and molecular alterations and really focused treatment of the various patient populations. So if you look at colorectal carcinoma, it's becoming a very small, it's a group of very small subsets that's developing. Such as BRAF, which is in less than 10% of our patient population, HER2 amplification, which is about 4% of our patient population, microsatellite instability high, which is 2% of our patient population or so, in regards to an inherited form of colorectal carcinoma. I think that it's really exciting where the field is going in regards to trying to provide optimal care that's specific to a patient largely based upon next generation sequencing or molecular sequencing. I think there's a lot of exciting new drugs that are currently being developed, antibody drug conjugates. There's a lot of bispecifics that are also being developed. And there's also some new interest, although early in development, regarding stem cell therapy for solid tumors. So I think in general, I think the field of oncology is very exciting in regards to GI malignancies. We may not be going as quickly as a gastric carcinoma, which has a lot of new recent developments. As an example, obviously we're not anywhere near close to being like where breast cancer is, where they have several drugs that are available to them. But I would say that for colorectal carcinoma, I think the field is evolving. I'm very hopeful, and I think that's the most important thing to keep in mind.
What do you think are the biggest unmet needs in anal, appendiceal, and colorectal cancers? And how are you addressing them through research?
I think the biggest unmet needs for all cancers in general, especially in GI cancers, is that if you are not a surgically resectable patient, meaning a patient that can't go on to surgical resection for cure, it's challenging because we still have to maintain the patient on some type of systemic therapy in order to prolong their overall survival as much as possible. And so I think there's still a lot of unmet needs in regards to drug development for patients that are in the so-called refractory setting, meaning that they've gone through 1 or 2, maybe 3 lines of therapy. And because we are prolonging the survival of our patients overall, there's still a lot of patients that are seeking 4th or 5th lines of therapy that are still in good shape, that are actually a good candidate for a clinical trial. So we still need further drug development in a patient population that may not have the specific molecular marker. So they may just be a patient that doesn't have any of those various small rare mutations, but they're excellent health still. So they still need treatment options. And I think it's really important for pharmaceutical companies to understand that the refractory patient population, is, at least in colorectal cancer, is still a huge unmet need. In regards to anal carcinoma, currently immune checkpoint inhibition or immunotherapy has moved to the frontline setting for the metastatic patient. And so now it's completely open in regards to drug development for a second line setting for that patient population. So that is completely an unmet need. And appendiceal cancer is still a very rare cancer. I know there's been a lot of increase in regards to acknowledgement of this cancer because it's just recently been separated out from colorectal cancer. Previously, they used to put colorectal cancer and appendiceal carcinoma together in regards to the National Cancer Center database. That has been revised more recently. And so now we're learning more about appendiceal carcinoma because it's getting more attention because now it's been individualized. And so now we're able to actually capture correct metrics. That is challenging because if you are a patient with appendiceal carcinoma, these patients tend to present also with more advanced disease. And as a result, they also have peritoneal disease or disease that involves the abdominal cavity. And as a result, they're at high risk for bowel obstruction. So it is very hard to get a pharmaceutical company interested in a very rare cancer, but also in a rare cancer that can potentially cause a bowel obstruction. So drug administration, if it's oral, may not necessarily be ideal for that patient population. So that is also another huge opportunity for drug development as well.
What factors do you believe are driving the rise in early-onset colorectal cancer, and how is the young adult cancer program at Vanderbilt addressing this growing challenge?
Thank you so much for that question. So that is a very that is the hot question. What exactly is driving the rise in early onset cancer and in colorectal cancer specifically? And the reality is that we do not know definitively what is causing the rising increase in this patient population. Clearly, I think it's multifactorial. I want to make sure we mention that what we're discussing is patients that do not have an inherited form of colorectal cancer. These are patients that have sporadic colorectal cancer. And so it's just spontaneous development of colorectal cancer. And the reality is we don't know the exact etiology because the screening age currently, at least in the United States, is 45. And the fact is I'm seeing patients, my youngest patient right now is 17. So there's data that shows that, for instance, obesity and metabolic syndromes and diabetes and other comorbidities can increase, alcohol intake, dietary habits, etc., can impact your risk of developing colorectal cancer. But I would say that we don't have any definitively to say exactly what is causing this. We do have some early data that suggests that there may be some impact on the microbiome, although that was a very select patient population, and it was just over 100 samples. I think that all of us are doing a lot of research, not only look at microbiome, but as well as other factors that may be accounting for this. And I think the most important thing that has been developed is the increased acknowledgement of this is a problem. And I think the most important thing we can do as a group, as an oncologist, is to work with our primary care physicians, to work with our gastroenterologists, work with our pediatricians to make sure the symptoms are recognized earlier on so that the patient can proceed to get a screening colonoscopy or some other screening test before they develop progressive symptoms or worsening symptoms. Our young adult cancers program obviously is, it's very focused on trying to help with this patient population and try to provide them as much support as possible. But we also want to try to learn as much as possible from the patients that we have within our own center. And as a result, we're fortunate enough, some patients are agreeable to allowing us to collect data about their treatment that they may be receiving, microbiome collections, stool, saliva, urine specimens, etc. So it is going to be a long-term project, and I think many individuals are trying to conduct that at this time. In addition, I think it's also really important to reduce the silos of various young adult cancers program. Not everybody has a young adult cancers program. Most institutions, if they're interested, have maybe a young adult colorectal program or a young adult GI program. We just happen to have one specific to just an age group, but not specific to any cancer. So I would say the most important thing we can do is work with our colleagues to try to find out why this is happening rather than just staying with our own institution. And I think you'll see that various groups are making these efforts, not only nationally, but as well as internationally, trying to identify the reason why this may be happening to our early onset patient population. So sorry for a long-winded answer, but there's no perfect answer since it's really not definitive.
So my next question will be, as Director for Strategic Relations at Vanderbilt, how do you view the role of pharma and biotech partnerships in accelerating translational research and improving patient care?
Thank you. So actually that question pertains exactly to what my job is. I specifically wanted to provide an opportunity for our basic scientists, our translational scientists, as well as our medical oncologists, as well as our medical teams, to collaborate together and to have a platform in which we can learn from our pharma colleagues about drugs early in development. And so my job as the Associate Director for Strategic Relations and Research Partnerships is really trying to invite members across the Cancer Center to learn about various drug X. Company X is going to come in and do a visit with their leadership, and we invite all the various interested parties into the Cancer Center to meet with those leaders of pharma and to try to learn about their pipeline, to try to see how we can collaborate together on any preclinical models as well as drugs in early development, not only to help them enroll. Obviously, of course, we want to continue to expand our portfolio in regards to clinical trials, treatment and opportunities for patients, but also how can we help provide more insight and more opportunities, not only for our postdocs, our residents and fellows in training, but also we want to help them refine their clinical trials if they're agreeable to learn from our insight. So I think that's really, really important. Sometimes companies may not be aware that what they're proposing may not necessarily be the best approach in a clinical setting, or maybe their models may not be the best models that they could have utilized. So we want to really get engaged early on. And it's not only just it's a mutual opportunity, right? We can learn from them and they can learn from us.
What scientific or clinical developments do you think will most profoundly change the landscape of GI cancer care in the next 5 to 10 years?
Yeah, that's another great question. So I think two of the things that will, I think, continue to evolve, not just besides other types of drug development, but obviously next generation sequencing is playing a key component in how we make decisions regarding which therapeutics to provide to patients, but also the sequence. And so I think, with time, these platforms continue to improve, and I think we will learn more from that. Number two, I think we were going to learn a lot more about the role of circulating tumor DNA. Currently, we use it more as a prognostic indicator, but I think it would be hopefully helpful in the future as a potential tool to help us make decisions, I hope, regarding therapy. Should we be changing therapy? So can the circulating tumor analytics impact our treatment sequence? And instead of waiting, 2 or 3 months for the next CAT scan, if you see a significant rise in our circulating tumor DNA, then should we change our current therapy? And I think we're going to, hopefully, with more data, move forward and hopefully be able to utilize circulating tumor DNA as another a larger tool than it already can be, not just prognosis, but maybe in regards to therapy and changing sequence. Right now, we're not there yet. The other thing I think that's really exciting, I think, is, there's a lot of interest in stem cell therapy, and I hope we can get more developments in that. Right now, everything's pretty much in phase 1, but I'm hoping that will be another unique opportunity for therapeutic approaches.
In your opinion, what are the most common misconceptions patients or even medical professionals have about GI cancers, and how do you work to change those perceptions?
I would say that some of the misperceptions, I guess that's what you're asking, about GI cancers, number one, I think people may not understand that, unfortunately, if you are not a surgical resectable candidate, we may need to have you on therapy for a very prolonged period, and the duration is not really known. And some individuals may think that some patients may look at chemotherapy or any type of therapy, doesn't have to be chemotherapy, but targeted therapy even, or immunotherapy, as something that they cannot live a very full life with it. And I think that is a very common misperception, because I think there are so many patients. I mean, nothing is perfect, and we understand there may be some potential side effects, but also, as a good multidisciplinary team, we also are very careful that whatever treatment we provide to patients, we want them to have good quality of life. So I think it's really important for the patient and the physician to communicate well to each other. And really, you don't have to be on chemotherapy every single week. I mean, we expect treatment breaks. We expect you to take time off with your family for vacations and holidays. But that you can live with your cancer. And there's many individuals that live very full lives despite having a diagnosis of stage 4 cancer. And I think it's really important to try to, I know it's difficult. Obviously, I'm a physician. I'm not the patient. But it's really important to keep in mind to try to be as optimistic as possible. I know some days are going to be very tough, but there are so many new developments that are occurring on a daily basis. And I think it's just really important for people to keep in mind there's a lot of amazing advances in medicine that can help prolong overall survival, and I would just not give up. There's always hope.
You've worked extensively with rare GI cancers, like, for example, we talked about appendiceal and anal cancers. What are some of the biggest challenges in advancing research and treatment for these rare types of tumors?
Yeah, one of the biggest challenges in treating a rare cancer is there's a lack of interest for pharmaceutical companies because they don't look at it as a financially as beneficial. However, I think that's where I've been very, very grateful to various organizations as well as smaller philanthropic organizations that provide grant support, as well as the NCI, where that has been very fruitful for me. No one was really interested before in anal carcinoma because it was considered to be rare, less than 10,000 patients per year originally. But because the NCI provided me funding through, now it's been 4 trials or so, that really got the attention for pharma because these trials, I've been very fortunate that some of these trials have been very positive. They changed the standard of care. And as a result, pharmaceutical companies then recognize that this is an opportunity. So I think that that's where the largest challenge is just being persistent. As an early investigator, I mean, I was looking at this early on creating investigator-initiated trials very, very early in my career when I was an assistant professor. But you have to be diligent. You have to have perseverance. And, as long as you know what what you want to achieve, and realize that you just have to be patient. It may take several years. That's probably one of the biggest challenges in treating rare cancers.
What's one piece of advice you would give to patients, their families, or maybe early career clinicians who want to lead and innovate in this field?
I think for patients, as you mentioned, the number one thing is to not give up hope and to, number one, listen to your body. Please reach out to your physician if you believe that you are not feeling well or if you have a symptom that's not resolved after a few weeks. Please go to your primary care physician or any physician for that matter, just to make sure you get a full evaluation. For patient advocates, I think their role has been critical in many aspects in clinical trials as well as colorectal cancer screening. And I'm sure it's the same in other cancers as well. And in regards to young investigators, I would just say, as I mentioned earlier, I think the most important thing is, number one, you need to work hard. I think it's very important that it is not presumed that things will be handed to you. You need to be able to come up with original ideas if you really want to become an academic investigator. That's not to say that everyone has to become an academic investigator. Some people are excellent physicians that are very happy just seeing patients or just enrolling to clinical trials without coming up with the ideas themselves and working directly with the pharma companies. And I think that's completely fine. I think every physician brings value regardless of whether or not they're an academic investigator or clinician versus a community practice physician. I would just say at the end of the day, just try to remain as optimistic as possible for your patients, but also try to be realistic when it is appropriate. And if you're meeting a new patient that's never been treated, it is extremely important to make sure you still get that patient hope. Unfortunately, I hear that sometimes that doesn't come across as well for some new patients with their new physician that they may have met. So,
and my last question for you will be, on the hardest days, what keeps you inspired, and what call to action would you share with viewers?
That's a very great question. And yes, it's hard being an oncologist, and there's a lot of sad moments. There's a lot of gratifying moments. And I think you always have to, as an oncologist, whether it's surgical, radiation, or medical oncologist, you have to look more often at the more positive aspects and the changes you've made in a patient's life rather than the negative aspects in regards to where you've had those uncomfortable discussions regarding hospice talks or end-of-life care. I think that is the most important thing. That's what really gets me motivated. And I often try to build relationships with my patients. And even though they may live 2 years or 5 years or 15 years, it's the time that I was able to give them to spend time with their family and friends. I think that's the most important to me, even if it was shorter than I would like. I think that's the most important thing to me because that allows them to have a more fulfilling life with their family and friends.
Dr. Yang, it was a really great honor for me to talk to you today and very inspiring to hear about you, the research about GI cancers and everything. Thank you so much.
Thanks so much.
Don't forget to like, comment, share, and subscribe to OncoDaily on YouTube. Hit the bell icon to stay updated.